So last time we were talking about the process of swallowing food and liquids. So swallowing, the term for it is deglutition, okay? So that's going to be the term for swallowing. Mastication, chewing, deglutition is for swallowing. It's mostly going to be an involuntary type process. The moment food hits your pharynx, everything from then on is going to be all involuntary, mediated through autonomic processes, predominantly cranial nerve number 10, or the vagus nerve. There's going to be 3 different phases involved in swallowing. The first is going to be the buccal phase, second is going to be pharyngeal, and then it's going to go down to the esophageal phase. So if you look at the image over here, as the individual is putting contents within their mouth, it looks like it's some sort of fluid or something. The moment the contents hit the soft and hard palate towards the back and posterior portion of the oral cavity, that's when you have the initiation of the buccal phase. At that point, food is going to be drawn down into the pharynx. At that point, if you look at the larynx over here, so the larynx is going to be like the vocal cords and including the epiglottis at the very top. The larynx is all going to elevate. As the larynx elevates, the epiglottis basically folds over to cover up the trachea so that food is going to enter down into the esophagus instead of into the windpipe. Right? So that's going to be the pharyngeal phase. And then once you pass the pharyngeal phase going down into the esophagus, that's going to be the esophageal phase. So this is a breakdown of all those different phases. I went backwards, huh? So it's going to be starting with the buccal phase. So as soon as you have the bolus of food or whatever it is, that, you know, if you're drinking something as well, once it enters into the oropharynx and it hits the soft palate, then you're going to get into the pharyngeal phase, which is going to be the next phase. So the pharyngeal phase effectively involves elevation of the larynx. As soon as you elevate the larynx, then the epiglottis basically folds over to cover up the trachea. And then the very final stage is going to be the esophageal phase. And it's all going to be through peristaltic type motions. We'll go into detail about the esophageal phase a little bit later. But then once you pass the lower esophageal sphincter, the lower esophageal sphincter is going to be kind of the border between the esophagus and the stomach. And it's going to sort of be generally around the level of the diaphragm. This can change if a person has for instance, a hiatal hernia. If a person has a hiatal hernia, then you have the lower esophageal sphincter as well as portions of the stomach basically penetrating through the diaphragm. And we're going to talk about why that's important, especially in terms of like GERD, which is gastroesophageal reflux disease. Oftentimes, patients with hiatal hernia are also going to secondarily have GERD as a consequence. So after long periods of time, long-standing GERD, eventually the person can start developing metaplasia or Barrett's esophagus, which can predispose the individual to getting esophageal cancer. But we're going to talk about that in a little bit. So the epiglottis, that's going to be that cartilaginous structure that effectively sits at the very top of the larynx. So it's going to be the more superior portion of the larynx. The epiglottis is extremely important in protecting the trachea during swallowing. And then all the movements that are associated with swallowing, as well as when we get into the lower GI, like the small intestines, large intestines, that's all going to be involving peristalsis, which is all going to be mediated by involuntary muscle contractions. Moving forward. Here's another image of an MRI of an individual swallowing. So here's the buccal phase as the food is entering towards the back of the oropharynx, applying pressure to the soft and hard palate. Then you get into the pharyngeal phase where you have the larynx lifting up. As the larynx lifts up, the epiglottis over here folds down to cover the trachea. And then as food enters down into the esophagus, that's when you initiate the esophageal phase of swallowing. Here's a side note of halitosis. Halitosis is just a fancy word for somebody with bad breath. It can be due to a lot of different things. Predominantly, it's going to be due to the presence of bacteria. your mouth is going to be writhing with bacteria. This when we do like throat cultures, for instance, and we cultivate different types of bacteria in the throat, there's going to be all sorts of, like, especially streptococcus type organism, strep pyogenes, strep mutans is going to be another common bacteria found within your oral cavity. It's going to be one of the major bacteria that causes tooth decay. So you have a lot of bacteria in your mouth, and in particular, anaerobes generally don't really smell great. And so if you have a lot of anaerobic type organisms in your mouth, that's going to lend itself to halitosis. Also, dehydration can cause halitosis as well. So if you have reduction in salivary production, that can also happen when you're waking up in the morning. You've been asleep all night, you haven't really been salivating as much during your sleep, so that can also result in halitosis. And the accumulation of allyl methyl sulfide due to the consumption of things like garlic and onions, that's actually not coming from the oral cavity, that's coming from the lungs. So these are going to be like secondary metabolites after consuming garlic and onions. And so that actually builds up in the blood when it gets its way to the lungs during respiration, right? That's what you actually get in terms of the odors from garlic. Cool. So moving on from that, the esophagus is going to be, of course, the important structure for the esophageal phase of swallowing. It's going to, the esophagus effectively arises at the level of the cricoid cartilage. So in your larynx, you have your thyroid cartilage. For us guys, that's our Adam's apple. That's going to be one of the more prominent cartilaginous landmarks in our neck. Below, about 2 fingers breadth below the thyroid cartilage, is going to be the cricoid cartilage. And that's effectively where the esophagus begins. The innervation for the esophagus is going to be emanating from cranial nerve number 10. Okay, so the vagus nerve is going to be the major nerve that innervates the esophagus. And so the innervations are going to be referred to as the esophageal plexus. So here's the side note on GERD. So GERD is gastroesophageal reflux disease. We're going to talk about peptic ulcer disease a little bit later when we get into like the stomach area. But GERD is effectively heartburn. Okay, so whenever you hear someone talking about heartburn, that's going to be gastroesophageal reflux disease. The major causes are going to be dietary, so certain types of foods might lend themselves to irritation and excessive release of stomach acids. So diet could also include alcohol consumption. So individuals that have GERD, it's generally recommended that they don't drink alcohol. Another thing as well is going to be smoking. Don't ask me about the mechanisms of that. I'm not really entirely clear, but smoking is one of the major causes of GERD. And then hiatal hernias. So a hiatal hernia is basically when you have the lower esophageal sphincter as well as portions of the stomach kind of perforating through the diaphragm. So if you ever have a patient that complains of heartburn, gastroesophageal reflux disease, recommend that they try to modify their diet. Maybe not eat as many spicy foods, which is kind of boring, but you choose your evils, and then definitely tell them to reduce their smoking. The biggest complications with GERD, because of like so much irritation, all that irritation over years and years and years can eventually become Barrett's esophagus. If you ever hear that term Barrett's esophagus, that's just metaplasia. Metaplasia means that you're having changes of the actual tissues that would normally be found within the mucosal membrane of the esophagus. So over time, you get changes of those tissues. As those tissues change further, that can be further complicated by esophageal cancer. Now this, of course, is going to happen over a very long period of time. It's not something that just happens overnight, right? So this is like long-standing gastroesophageal reflux disease. So this is what it looks like when you have Barrett's esophagus. Barrett's esophagus, of course, that's the metaplastic phase where you just have changes of all those cell types within those tissues. Here's the stomach. Those are all the rugae within the stomach. And then here's the Barrett's esophagus. This would be the lower esophageal sphincter right here. And you can see that all of that esophagus is like extremely inflamed. And then right here, this would actually be esophageal cancer, where you have cancerous development over a long long-standing Barrett's esophagus with metaplasia. We're going to talk about peptic ulcer disease in the second part of this chapter, but with peptic ulcer disease, the major way that you treat that, it would be through PPIs, so proton pump inhibitors. You can get a lot of these drugs over the counter, so like omeprazole is going to be one of the most common ones that fall under that category. To treat GERD, same thing. You take omeprazole, which is a proton pump inhibitor. One of my best friends, he has this all the time. He's also a chronic smoker and a chronic drinker too. And so he doesn't stop. He constantly has it. But he has been taking omeprazole probably for about 15 years now. So he's been taking it for a long time, which with relative degrees of success in treating his GERD. So lifestyle modifications are often the best option in treating those types of conditions, but to each their own. In terms of the involuntary movement throughout the GI tract. Now, the GI tract is mostly going to be made up of smooth muscle. So smooth muscle does not have striations. It's going to be involuntary. For the type of movements you see when we're talking about peristalsis as well as segmentation, that's all going to be mostly spontaneous. You get spontaneous depolarization that allows for the contraction of smooth muscles. There are going to be pace setter cells within the GI tract. So those pace setter cells can help to control the actual rhythm of peristalsis. But for the most part, it's all going to be pretty random, pretty spontaneous. Whenever you do a physical exam on a patient in the future, when you have your little stethoscope on and you're auscultating bowel sounds, you're going to be listening to the sounds of peristalsis. And the sounds are going to be very random, right? And they happen pretty like sporadically. You can hear maybe bowel sounds up to 5 times within a minute, depending on when the person last ate, whether or not they're actually undergoing like active digestion. So it's going to be a pretty random process, peristalsis. So this is peristalsis on the left, and on the right is going to be segmentation. So peristalsis is effectively the way that food is able to just move throughout the entire GI tract. Right? With segmentation, it's a little bit different. Segmentation is allowing kind of for like more of a mechanical type of digestion. It's helping to break things down into smaller parts, so it allows things to be able to become more readily absorbed throughout the small intestines. So in terms of peristalsis, those are going to be waves. Okay, so it's waves rather than those little segments. And as the wave continues down, whether it's the esophagus or the small intestine, you're going to have contraction upstream from the bolus. So contraction upstream from the bolus allows the bolus to move downstream. Downstream, you're going to have relaxation. And that whole entire wave is going to move in a smooth type fashion, especially within the esophagus. So let's watch a little video on what peristalsis looks like. So this is externally. You can actually visualize peristalsis. If somebody has any sort of like GI issues or distension in the GI, sometimes you can literally just watch the patient's abdomen, and you can actually visualize the peristalsis taking place. You can also see this in really young neonates as well. So here's an image of a neonate that has pyloric stenosis. So this kid is actually, there's an actual issue with the child. So you can sit there and watch the actual peristalsis taking place in the abdomen. So all of this is like the slow motion throughout the GI tract. It's very subtle, but I know it's very subtle. Can you guys see that at all? So you can see it, especially right over here. You can kind of watch the shadow as it slowly moves over towards the right. Kind of hard to tell, but that's the best video I could find. I know there's probably other ones out there, but let's watch this video. This one's kind of fun. So this is during a laparoscopic type surgery with cameras. So you can actually see that peristalsis taking place. So you see peristalsis is going to be moving things kind of longitudinally. when you see these type of contractions, that's segmentation. So the segmentation is kind of happening more of like, there's like circumferential type muscles versus longitudinal muscles. The longitudinal muscles are going to be more involved in like, well, they're both going to be involved in peristalsis, but segmentation is mostly going to be those like circular type smooth muscles. Cool. So circular muscles versus longitudinal muscles. The circular muscles are the ones that are going to be contracting behind or upstream from the bolus, allowing the bolus to move further along down the GI tract. The longitudinal muscles are going to basically shorten the length of the GI tract. So you have contraction with the circular muscles, moves the bolus down. Those longitudinal muscles allow for shortening, so you can helps to propel the bolus further down down the GI tract. Here's a video. Let me turn the audio off. Sorry. Let me turn the audio off because it's very obnoxious. There we go. Okay. So that right there is the lower esophageal sphincter. And then all the way down, this is the stomach right here, all the way down that other opening towards the end, that was the pyloric sphincter. All right. So that would be an example of an endoscope. That's what you would see on endoscopy. Cool. So cranial nerve number 10 helps with peristalsis. You also have cranial nerve number 9 allowing for peristalsis in the esophagus. One of the major ones is going to be cranial nerve 10, though. So when you swallow something during the esophageal phase, as the bolus goes down the esophagus, you have a couple different waves. You're going to have the first wave. This is all going to be automatic. The first wave is going to last anywhere between 8 to 9 seconds. It travels all the way down. Now, if you take a drink of water or something like that, it's going to travel a lot faster down the esophagus. But regardless of how fast the bolus travels down, this peristaltic wave is going to happen at the same rate. So even if whatever you swallow makes its way past the lower esophageal sphincter, you're still going to get that peristaltic wave moving from the superior region of the esophagus all the way down to the inferior portion. And then you get secondary waves. Secondary waves are assuming that something might have gotten stuck within the esophagus. Cool. And then in terms of segmentation, that's the way you are able to break down the bolus as well as breaking down chyme. It's not going to really follow any sort of pattern. So peristalsis, you have kind of like those like pace setter type cells that kind of help to kind of regulate the rate of peristalsis. But with segmentation, it's just kind of happening randomly. And then once you get down into the large intestines, when we get into large intestines towards the end of section 3 of chapter 25, we're going to talk about the haustra. Those are going to be kind of like large outpouchings within the large intestines. And the haustra are going to be very much involved in segmentation. When the haustra undergoes segmentation, it's effectively going to allow for maximum reabsorption of water. So once we get into large intestine, we're going to talk about that's one of the major functions of the large intestine is to help to reabsorb water. And so when you have haustral segmentations, that's basically going to allow for some of the more like large solid waste before it gets excreted so that you can be able to reabsorb as much water from that as possible. Cool. So that's the end of part 1. So let's go ahead and do a quizzes before we move on to part 2. All right, so I counted 50 people. So if you weren't able to log in at all, just give us your name. Oh, there we go. Cool. All right, so the sublingual gland, that's going to be the least amount of saliva produced, okay? So in terms of percentages, submandibular gland, about 70% of all of your saliva is produced by your submandibular gland. Parotid gland, about 25%, and then sublingual is about 5%. Okay, so the submandibular gland is going to be, of all those, the most crucial. Now, in terms of the ducts that are associated with both, make sure that's not, yep, that's not on here. So what is the duct through which saliva is able to enter into the oral cavity from the parotid gland? You guys remember? First of all, where is it located? Where's the parotid gland located? It's going to be kind of right next to your masseter, below the zygomatic arch, anterior to the ears, okay? And then where does the gland release saliva? You guys remember that? Huh? Stenton's gland, which is going to be at the second molar, right? So it's going to be the second molar in your maxillary area. So it's going to be your upper, the upper molars. What about the submandibular gland? What is the duct through which the submandibular gland releases saliva? Starts with a W. Yeah, Wharton's duct. Good. What about the sublingual? Yeah, so the Ravinus's duct is going to be sublingual. So make sure you know which ducts are associated with each of these different glands. All right, so let's go through each of these. What are the major enzymes that break down proteins? Pepsin is one. What else? Protease. You guys heard of protease before? We're going to talk a little bit about that when we get into the pancreas. That's one of the enzymes that's released by the pancreas is protease. For carbohydrates, amylase. What about for fats? Lipase. Good. Excellent. So lipase breaks down fats. What about cellulose? Can we break down cellulose? No. Yeah, we can't break down cellulose. Our nearest ancestors, some of the great apes that eat a lot of leaves, they're able to break down cellulose. But even if you can break down cellulose, you don't really get much nutritional value from that. That's why, like chimpanzees, for instance, they basically spend all day just like eating leaves. That's why they have really large distended abdomens, because they have a really long GI tract so that they can actually be able to break down cellulose and derive at least a little bit of nutritional value from what they eat. We just talked about that. I hope you guys all get it right. Yes, both B and C. Inferior to the zygomatic arch, that's your cheekbones. Also anterior to your ears. Okay? So make sure you know the location of the parotid gland. Inferior to the mandible, that would be the submandibular gland, as the name implies. Good, amylase. So salivary serous cells are going to be mostly responsible for secreting amylase, which helps to initiate the digestion of complex carbohydrates. There's mucin type cells that secrete mucus. Okay, pepsin we're going to talk about in part 2. Pepsin is going to be the active form of pepsinogen, which is going to be released by chief cells in the stomach. Okay, so chief cells release pepsinogen. Once pepsinogen gets in contact with hydrochloric acid, it turns into the active form pepsin, which helps to break down peptides or proteins. Cholecystokinin, we're going to talk about later, helps to stimulate the gallbladder to contract so that you can release bile, so that you can help emulsify lipids and fats. Bless you. So think salivation, think involuntary. It's going to be parasympathetic. Think rest and digest. Okay, rest and digest, parasympathetic. What are some of the risk factors for GERD? Smoking, diet, so like spicy foods. What else? Alcohol, for sure. Cool. You guys got all them, got that one correct, so perfect. All those things can happen. Looks to me like everybody got this one correct, which is awesome. Good, yeah. So segmentation is going to be a little bit different, right? Segmentation is random, helps to kind of break down chyme as well as fecal matter into smaller parts to maximize the surface area. A couple more. Good. Smooth muscles are involuntary. Last one, and then we'll move on to part 2. All right. Good. Most of you guys got that correct, which is awesome. Cool. Any questions so far? All right. Awesome. Let's go into part 2. Turn that off. Cool. All right. So chapter 25, part 2. This is within the intestines. That's a histological slide of what you would find with the intestines. You can't really see it on here, but that says goblet cell. If you ever hear a term goblet cell, those are going to be cells that release mucus. So you get a lot of mucus secretions within the stomach, as well as the GI tract, or the rest of the GI tract, small intestines. It helps to kind of serve as a lubrication to allow things to pass through, like all the chyme that's getting passed through the GI. It also, when you have mucus in the mucosal membrane, also helps to protect the delicate tissues from acidic pH, right? So low pH can cause damage to a lot of these cells, and so goblet cells and mucus secreting cells are going to be able to help protect those different regions. So let's talk about the 4 major layers of the GI tract. So let's start from inside going out. Okay, so within the lumen of the GI tract, you're going to have the mucosa. Below that, you're going to have the submucosa. Then you're going to have the muscularis, where you find different smooth muscle groups. There's a couple of them that we're going to go into more details about. And then the serosa is going to be everything on the external layers of the GI tract. That's basically what you, if you were to do like a laparoscopic surgery and you were to visualize the small intestines, you would be looking at the serosa of the small intestines. And then we're going to talk a little bit about the mesentery, right? So the mesenteric region of the small intestines, you're going to find lots of vascularization. You're also going to find a lot of fat in those areas too. But the vascularization is especially important because that's how you are able to absorb nutrients from the GI tract. So lots of blood vessels within the GI tract. So the mucosa is going to be where you see absorption of nutrients as well as the secretion of different things. All sorts of different compounds are going to be secreted at the layer of the mucosa. We're going to talk about brush border enzymes a little bit later, including things like lactase, maltase, trypsinogen. So those are all going to be things that can be secreted at the mucosal membrane. Also, mucus, right? Mucosal membrane, you have a lot of mucus secretion at those layers. Then the submucosal layer, that's where you're going to find the Meissner's plexus. So it's going to be a series of innervation that innervates the submucosa. The Meissner's plexus is especially going to be involved in like the release of different types of like enzymes, digestive enzymes, things like that. And then when you get into the muscularis, that's going to be where you have a couple different layers of smooth muscle. You're going to find the Auerbach's plexus. The Auerbach's plexus is basically going to be responsible for things like peristalsis as well as segmentation. We're going to talk about those different layers of muscle within the muscularis later. And then the serosa, the serosa is going to be the outer layer of the GI tract. So let's go into each of these different layers in a little bit more detail. So in the mucosal membrane, that's where you're going to find epithelial tissues. So those are going to be involved in things like absorption, things like secretions. You're also going to find the lamina propria. When you hear the term lamina propria, you're thinking that it's going to be the lining of the mucosal membrane. So it's kind of like a connective type tissue. So lamina propria, just think connective type tissue. Within that connective tissue, that's where you're going to find like all the blood vessels that allow for absorption of nutrients. You're also going to find nerves within the lamina propria. Remember lacteals? That's where you get lipid absorption at the level of the mucosa. And you're also going to find some smooth muscle at the layer of the mucosa as well. The smooth muscle layer is going to be much thinner than what you find within the muscularis region, because the muscularis, you have a couple different layers of muscle, circular as well as the longitudinal muscles. Remember, those circular muscles allow for segmentation. Those longitudinal muscles can help to like kind of shorten the length of the GI tract. The submucosa, one of the most important things is going to be the Meissner's plexus. Now, the Meissner's plexus is also referred to as the submucosal plexus, but for the sake of for this class, try to be familiar with both of these terms. When you hear submucosal plexus, know that it's interchangeable with the Meissner's plexus. The Meissner's plexus, that's going to be involved in the regulation of absorption, regulation of different cells within the mucosal regions. It's also going to help to vasodilate, vasoconstrict. So for instance, if you just got done eating a large, heavy meal, and now you're in a rest and digest phase in a parasympathetic type response, now you're going to get vasodilation at the level of your GI tract, right? So you can help to now absorb as much of the nutrients that you consumed as possible. So the Meissner's plexus would be heavily involved in that whole entire process. The other layer beyond that is going to be the muscularis layer. And as the name implies, that's where you find the bulk of your smooth muscles. Now, you're going to have a couple different layers of smooth muscle. On the innermost layer, you're going to have the circular muscles. Those help to allow for peristalsis as well as to allow for segmentation. Outside of that layer, you're going to have the longitudinal smooth muscles, right, that can help to shorten the length of the GI tract. So in other words, you're going to have two layers of smooth muscle, and you're also going to have a series of innervations that help to stimulate those smooth muscles to contract. That's going to be referred to as the Auerbach's plexus, also known as the myenteric plexus. Okay, so those two words are going to be synonymous with each other. So again, for the sake of this class, make sure you're comfortable with both of those terms, okay? Moving forward, once you get to the serosa, that's going to be the more superficial layer of the GI tract. That's also going to be referred to as the visceral peritoneum. We're going to talk about what the peritoneal cavity is made up of in a second, but know that the visceral peritoneum, that's going to be what's attached to the viscera. It is the most superficial layer, and you're going to have serous fluids. Those serous fluids that get produced are going to help to basically lubricate the GI tract. So as you're undergoing peristalsis, you're not going to have too much friction as the different organs are all going to be rubbing up against each other. So serous fluid basically helps to reduce the amount of friction within those layers. In terms of the way these different regions are going to be controlled, or the different cell types are going to be controlled, you have a couple different ways that can happen. You can have hormonal or endocrine type secretions. We're going to talk about a couple of the different types of hormones a little bit later. But those hormones get secreted directly into the blood. Remember, hormones get secreted into the blood so they can communicate with other tissues further away from the secreting cells. So we're going to talk about the different hormones like gastrin, for example. You also have paracrine type cells and paracrine type activity. Remember, para, that's going to be adjacent to. So those are going to be the way that cells that are next to each other can communicate. And then you also have neuronal type communication. Remember, we have the Auerbach's as well as the Meissner's plexus. That's going to be involved in like neuronal type communication. So let's see here. Control, blah, blah, blah. Let's see here with the motor neurons. So with neuronal control, just know that you have the two major nerve plexes that are involved in that: submucosal Meissner and the myenteric Auerbach's plexus. And that's what another image of what that looks like. So you got the mucosa. Within the submucosa, You're going to have the Meissner's plexus. So submucosa would be the Meissner's plexus. And then in the myenteric plexus, that's also referred to as the Auerbach's plexus. Cool, let's talk about the different types of reflexes that could happen. So you have both short and you have long reflexes that can take place within the GI tract. Short reflexes are going to be they're going to have more like a local stimulation, okay? So oftentimes the short reflexes are going to be due to chemical changes, so like pH changes, as well as pressure differences. So if you have chyme passing through a local region, that's going to stimulate a short type reflex. And as I mentioned, it's going to be very small type sections. So here are short reflexes. You can have chemoreceptors. So in other words, a change in pH levels can stimulate that. And mechanoreceptors, which are responding to changes in pressure, can result in a short reflex. And those short reflexes are going to stimulate those nerves to be able to undergo peristalsis as well as segmentation. So that's going to be a local short reflex control. Long reflexes are going to be involved in the central nervous system. Okay, long reflexes, they're going to involve more like higher cortical function. They can also involve external stimuli. So we're going to talk about the cephalic phase. The cephalic phase is going to be characterized by sight and smell. If you're sitting here, you're hungry, you're thinking of food for whatever reason, even though we passed lunch already. But if you didn't have lunch today and now you're thinking about food, all of a sudden that's going to engage the cephalic phase. And during the cephalic phase, that's going to stimulate the release of different types of digestive enzymes, different types of hormones that can come in that are basically helping to prepare the GI tract to receive food. So that can be one of the first types of stimuli that help to stimulate the central nervous system. Also, once you start eating food, once food starts entering into the GI tract as a whole, that can also start stimulating those chemoreceptors as well as the mechanoreceptors, and those can send signals back into the central nervous system to help increase the amount of long reflexes taking place. Now, once those long reflexes taking place, you're going to have your effector cells. The effector cells are going to now start allowing for smooth muscle contraction. It's also going to allow for releasing of certain types of digestive enzymes and certain types of hormones as well, which we're going to go into more detail later. Here's another image of what that all looks like. So if you have stimulation of the myenteric plexus or the submucosal plexus, aka the Meissner plexus and the Auerbach's plexus, respectively, then those are all going to involve stimulation of both long and short reflexes. Okay, so think short reflexes, that's going to be in a local level, long reflexes involving the central nervous system. Now, there's a lot of different peptides that are involved in digestion. We're going to go over quite a few of these. We're going to talk about cholecystokinin, secretin, GIP, ghrelin, gastrin. So we're going to go through all of these different peptides in more detail. The only ones that we're going to really skip here are GL. We're going to skip all these ones over here on the bottom. We're not going to talk about any of these over here. And we're also not going to really talk about amylin. Everything else we're going to go into a lot of detail about. So what's going on here in terms of local factors, as I mentioned, changes in pH, change in chemical composition, as well as things like changes in pressure, right? Increased amount of pressure due to the presence of chyme or food that's being digested. All of that can basically start having effects on those types of like stretch receptors, affecting those different, like the myenteric plexus, Auerbach's plexus, etc. And all that is effectively going to help to increase the amount of peristalsis as well as the release of different types of digestive enzymes. As I mentioned earlier about the peritoneum, you're going to have two different regions of the peritoneum. Everything that surrounds organs, if it's surrounding the small intestines, large intestines, the stomach, that's all going to be referred to as the visceral peritoneum, right? That's going to be kind of associated with the serosa layer of your GI tract. If it's surrounding the actual peritoneal cavity itself, that's going to be referred to as the parietal peritoneum. And within that, you're going to have peritoneal type fluids. And those fluids effectively just act as a way to allow for lubrication of organs. So let's get into some of the different organs. We already talked about the esophagus and all that. So now let's start getting into the stomach and the rest of the GI tract. In terms of the stomach, there's going to be 4 different regions. You have the cardia, which is going to be this region right here. You have the fundus, which is kind of like the base of the stomach. The body, which is the rest of the stomach here. It's like one of the larger portions of the stomach. And then you have the pylorus. The pylorus is going to be the border between the stomach and the small intestines. The small intestines begins with the duodenum. Okay, so the pylorus, you're going to be able to, the pyloric sphincter remains closed as the stomach is undergoing chemical and mechanical digestion. As chyme is ready to enter the small intestines, then you have relaxation of the pyloric sphincter. Nothing really too crazy here. Oh yeah, and in terms of the curvature, lesser curvature, that's going to be this portion here, and the larger curvature is going to be the larger portion of the stomach. In terms of what the stomach is made of on the inside, you have rugae. And rugae basically allows for increase in the amount of surface tension. Anyone in here from Mexico? So have you ever had menudo before? So yeah, menudo, that's basically stomach of a cow. Kind of unsettling at first, but you know, my mom actually makes this, and it turns out pretty good. I learned to love it, but at first it's a little creepy. Right? You have all like the little rugae and stuff. It's kind of hard to look at. It's kind of like lingua. Do you like lingua? It's good. You can't look at it. If you look at it, it's like, I don't know. It's kind of, lingua is cow tongue, by the way. Anyways, moving on. So in terms of the function of the stomach, so the stomach does a lot of things. It's going to be involved in a lot of different types of peptide release, right? So you can have the release of like, you know, gastrin, things like that. You're also going to have the release of hydrochloric acid, which helps to chemically break things down. But you're also going to have mechanical breakdown of food, right? As as food enters into the stomach is going to start churning, and all that churning is going to allow for the physical mechanical breakdown of food. You're also going to have the release of different types of enzymes, release of acids. All those are going to allow for chemical digestion of food. And very important here, you have cells that are going to be involved in the release of intrinsic factor. Intrinsic factor is going to be extremely important for the ability for you to be able to absorb vitamin B12. If you don't have intrinsic factor, you're going to eventually develop pernicious anemia. There's various types of anemia, but the type of anemia specifically involved in vitamin B12 deficiency is referred to as pernicious anemia. And it's going to involve multiple different things, including kind of like a macrocytic enlargement of the red blood cells, and the red blood cells become a little defective as a consequence. But when intrinsic factor is released, it allows for absorption of vitamin B12 at the level of the ileum. So when we talk about the small intestines, the most proximal portion is the duodenum, second portion is the jejunum, and then the very last portion of the small intestine is the ileum. And the ileum is what is involved in the absorption of vitamin B12, among other things. In terms of the cells of the stomach that are really important, you have a couple major ones: parietal cells, G cells, and chief cells. G cells, pretty straightforward. They're mostly involved in the secretion of gastrin. And the gastrin, when it's released, it's going to enter into the bloodstream, and it's going to eventually allow for increase in gastric motility. Parietal cells are going to be involved in the secretion of both intrinsic factor, that's what IF stands for over here, intrinsic factor, as well as hydrochloric acid. So parietal cells are really important in the release of acids to allow for chemical digestion of food. And then the other important cells are going to be chief cells. The main things that chief cells release are going to be pepsinogen. Pepsinogen is the inactive form of pepsin. Pepsinogen gets released, and then once it comes into contact with hydrochloric acid, then it eventually gets converted into pepsin. And pepsin is going to be an important peptide that allows to break down amino acids. Okay, so you have pepsin and protease. Those are going to be important compounds in the breakdown of proteins. And then the other thing that chief cells help to release is gastric lipase. Remember, lipase, think lipids, so it's going to help to break down lipids. We're going to go into detail into all these different cell types in a little bit, but just know parietal cells, you're thinking hydrochloric acid, you're thinking intrinsic factor. Chief cells, you're thinking pepsinogen as well as lipase. And then parietal cells, we talked about that already here with hydrochloric acid, intrinsic factor. This is really important. If you're not able to absorb vitamin B12, that's going to result in pernicious anemia. So I have an image here. So this is what you would see on a peripheral blood smear of pernicious anemia. These are the erythrocytes with pernicious anemia. They're all going to be kind of like malformed. They're actually going to be a little bit larger than they're supposed to be. So they refer to this as a macrocytic. Macrocytic means enlargement of the cell types. So it's a macrocytic type of anemia. Hyperchromic is another term that's important. Hypochromic means you have a reduction in the actual pigmentation of those red blood cells. So it's macrocytic, hyperchromic type anemia. You can also have ovalocytes, so they kind of form these like weird oval type shapes. But long story short, these are defective red blood cells. And so that's why it's referred to as an anemic type condition. They can also affect the neutrophils as well. So generally speaking, neutrophils are going to have about 3 lobes to their nuclei. So it's a multi-lobular nucleus. But with pernicious anemia, you can have many more lobes than that. You can get up to like 6 different lobes of your neutrophils. You can also see this type of anemia presentation. It wouldn't be referred to as pernicious anemia. Pernicious anemia is specifically vitamin B12, but you can get this type, like similar type of anemia with the shape of the red blood cells if you have a folate deficiency. So that's just a side note. Just know that pernicious anemia is going to be associated with vitamin B12 deficiency, which is going to be a reduction in intrinsic factor production. So let's talk about hydrochloric acid production. So hydrochloric acid, what kind of cells was that? You guys remember? Parietal cells, good. So at the level of the parietal cells, that's where you're going to see the production of hydrochloric acid. Now there's going to be a couple of enzymes that are involved in the production of hydrochloric acid that we kind of already talked about. We talked about some of these enzymes when we were referring to carbon dioxide and how carbon dioxide gets turned into carbonic acid, right? So similar process in the forming of hydrochloric acid. So first you have carbon dioxide and water. Carbonic anhydrase. You remember that enzyme from when we talked about like buffering the blood as well as the transport of carbon dioxide? Same process. You have carbon dioxide turning into carbonic acid. Okay? So once carbonic acid gets produced, the carbonic acid, the bicarbonate, very similar to the red blood cell. Remember we had bicarbonate being removed from the red blood cell in exchange for chloride ions. Same exact thing is happening over here. Bicarbonate is actually being sent off into the interstitial fluid in exchange for chloride ions. As that chloride ion enters into the cell, both chloride ion as well as protons in the form of the hydrogen proton can be released into the lumen of the gastric glands. Okay? So this is actually how you produce hydrochloric acid. Now, one thing to keep in mind about this whole entire process is that this process can be inhibited by the use of proton pump inhibitors. And we talked about GERD. This can also be used to help prevent peptic ulcer disease as well. So peptic ulcer disease, where you have ulcerations within the mucosal lining of the stomach. If you use a proton pump inhibitor, you can basically prevent the ability for your parietal cells to release hydrochloric acid. These are all different examples of proton pump inhibitors. Omeprazole is a very commonly used one. You can buy it generic, or you can get it in different brand names like Prilosec. You can't really see it here, but ranitidine is going to be another one. Lansoprazole is another one. So lots of different drugs that you can use to help reduce the amount of hydrochloric acid release. So let's talk about chief cells. So we talked about parietal cells. Okay, parietal cells, you're thinking intrinsic factor, hydrochloric acid. Chief cells, you're thinking pepsinogen as well as gastric lipase. So chief cells are going to be pretty abundant down at the base of these gastric type glands. They're going to be secreting pepsinogen. When you hear the term pepsinogen, that is an inactive form of pepsin. Pepsinogen requires the presence of hydrochloric acid in order for it to be converted into pepsin. Once it gets converted into pepsin, that's what helps to break down different types of peptides. Okay, so it's going to be a proteolytic type enzyme. And then gastric lipase, super straightforward. It's just basically going to break down triglycerides or fats. Nothing really too crazy there. So yeah, this is what's going on here with pepsinogen. Gets released by the chief cells. Parietal cells are what release hydrochloric acid. Once pepsinogen comes in contact with that hydrochloric acid, it turns into pepsin, and then pepsin is going to be able to break down proteins. Very straightforward stuff. So let's talk about some of the endocrine cells as well. So I mentioned that we're going to talk about gastrin, right? So gastrin, when gastrin gets released, it's part of the endocrine system. So in other words, it's going to enter into the blood. So it gets into the blood, so it becomes more of a systemic. It enters into the systemic circulation. What gastrin basically does, it helps to increase gut motility. It also helps to increase hydrochloric acid production. And where do, well, never mind, I already answered that question here. From where? Actually, yeah, from where? Hydrochloric acid. Where again is that coming from? Which type of cells? Parietal cells. Chief cells, what do chief cells produce? Pepsinogen and gastric lipase. Awesome. We're not really going to go into too much detail about D cells, but D cells are going to basically release somatostatin. Remember when you hear the term statin, that basically inhibits the release of things? So somatostatin is basically going to help to inhibit gastrin release. So it's going to help to reduce gut motility. It's going to help to reduce the amount of hydrochloric acid that's produced. But that's a side note. We're not really going to go into too much detail about D cells. And then mucus cells are going to be really important to help protect the mucosal layers from the low pH of the stomach. Within the stomach, the pH can dip down to about 2, which is really, really low. Right? 7 is about neutral. Once you get down to a level of 2 in terms of pH, that's very, very acidic. And so if you didn't have mucus production, then you would increase your rates of developing peptic ulcer disease. And so we're going to talk about peptic ulcer disease in a second. But let's do just a really quick overview here. So you can think of G cells as being kind of like one of the first steps taking place. G cells are going to help to release gastrin. Gastrin is going to help to increase gut motility. By the way, just remember that gastrin is going to enter into the blood because it's basically considered a hormone. It's a part of the endocrine system. So then gastrin is going to help increase gut motility. It's also going to help chief cells release pepsinogen as well as lipase. But also, more importantly, for parietal cells, it's going to help release hydrochloric acid. So in order for that pepsinogen to get activated, you need hydrochloric acid. Okay, so hydrochloric acid helps pepsinogen convert into pepsin. So know that G cells are going to be really important in helping to stimulate this entire process to take place. Cool. So let's talk about the different phases of gastric secretion. So I already kind of mentioned the cephalic phase. The cephalic phase is literally starting with your thoughts, sight and sound, right? So thoughts, sight, sound, visual stimuli, smells, all those things are going to be involved in the cephalic phase of gastric secretion. Then we're going to talk about gastric phase as well as the intestinal phase afterwards. So here's the cephalic phase. Here. So with the cephalic phase, you have sights, smells, odors, things like that. That's going to basically help stimulate the vagus nerves. What it's effectively doing to the GI tract, it's starting to prime the GI tract. It's starting to get the GI tract ready to consume a meal. But then once you do consume the meal, then food is going to enter into the stomach, and it's going to help release lots of different things, including gastrin, right? Gastrin helps to increase gut motility. It also helps to increase hydrochloric acid production from your parietal cells. You also have histamine release as well. Remember, histamine kind of helps to vasodilate, so it kind of helps to like speed this process up. And so that's all going to be involved in the stretching. It's like stretch receptors. So that's going to be the gastric phase. And then once you get into the intestinal phase, that's when food starts entering into the duodenum, for example. Once you get food entering into the duodenum, then you get the secretion of things like cholecystokinin, which is CCK. Cholecystokinin now is going to help to contract the gallbladder to help release bile into the duodenum and down into the small intestine so that now you can start absorbing lipids. So we're going to talk about all those different chemicals later on in more detail. So cephalic phase, think about the cephalic phase as being parasympathetically mediated. Okay, so think about the whole rest and digest component of the autonomic nervous system. So it starts here with the cephalic phase. Effectively, it's priming the stomach to receive food. So you have chief cells are going to be releasing pepsinogen. Parietal cells are the ones that release hydrochloric acid. Pepsinogen can get converted into pepsin. So now you're going to get ready to start digesting food chemically. And then G cells, of course, are going to help to increase gut motility. Then once you get into the gastric phase, that's going to be mostly involved in stretch receptors. That's food literally in the stomach, stimulating different types of cells to do different things, such as release more hydrochloric acid so that you can further reduce the level of pH. So that's going to be released by the parietal cells. It's going to also help to increase more gastrin release to allow for further stimulation of gut motility so you can undergo more mechanical digestion of food. And then the intestinal phase, that's when you get, when food starts entering into the duodenum. Once food enters into the duodenum, that's considered the intestinal phase, and that's going to involve several different compounds, including cholecystokinin, GIP, which we're going to talk about later, as well as secretin. Secretin is going to help to stimulate the release of pancreatic enzymes. So, any questions so far? Awesome. So, in terms of what's going on at the level of the stomach can become quite distended. So, it can accommodate up to 1.5 liters of material. So, back to my wine bottle reference, 1.5 liters would be the size of 2 standard wine bottles. So, that's quite a lot of material that can fit inside the stomach. When you start eating, right? When you start eating, you're releasing amylase from through your saliva. So you already have chemical digestion beginning as soon as you put food into your mouth. So chemical digestion is already beginning to take place. You also have lipase that gets secreted at the level of your saliva as well. So you have lipase breaking down lipids and fats. But once things get down to your stomach, that's where you have the bulk of your mechanical and chemical digestion taking place. The pH level gets really low, so it's extremely acidic. Because of that really low pH, if you have any sort of compromise to the mucosal layers, you can run the risk of getting peptic ulcer disease, which we'll talk about in a moment. One thing to keep in mind about absorption, the majority of things that are being absorbed in your GI tract are going to be taking place at the level of the small intestines. Okay? It's like 90% or more of everything that you consume gets absorbed at the small intestines. You do get a little bit of absorption at the level of the stomach. Alcohol is going to be one example, and certain drugs as well, like aspirin, can get absorbed at the small intestine. So that's why when you drink alcohol, it generally hits you pretty rapidly because you're getting absorption right away. It's pretty quick. In terms of food digestion, though, food is going to remain within the stomach for quite some time, anywhere between 2 to 4 hours before it eventually makes its way into the duodenum. Now, in terms of hormones, we talked about these hormones before, but let's talk about them again now that we're getting into GI. But ghrelin versus leptin. Ghrelin is going to be the hormone that's secreted when you're hungry, right? So it's going to kind of be like the hunger hormone. I like to think of it as like your stomach making noises. It's going grr, right? So that's ghrelin. Your stomach is hungry. Okay? Leptin is going to be the opposite. Leptin is going to be secreted by adipocytes. So it's going to be secreted by your fatty tissues. And that's basically the satiety hormone. It means that you're pretty well fed. You do not need to eat anything else. Okay? So ghrelin, hungry. Leptin, you're pretty much well fed. So in terms of peptic ulcer disease, as I mentioned, stomach pH gets really low. It can dip down to about 2, so very, very acidic. If you have any compromise to the mucosal layer, then you can start having those stomach acids beginning to digest the tissues within the mucosal membrane. Those peptic ulcers can get all the way down into the submucosa, so they can get pretty deep. This image doesn't show, but sometimes it can go even further than that. It can actually perforate certain blood vessels. So patients with peptic ulcer disease sometimes might actually get a little bit of like vomiting blood, regurgitating blood. Okay, so hematemesis. Okay, so that'd be like the regurgitation of blood. Something else to keep in mind too, they might also get melena, which is like really dark stool. When the patient gets melena or like really black looking stool, that's usually an upper GI bleed. That means that the blood got digested. Once it gets digested, it becomes highly oxidized, and then it lends itself to becoming really dark in color. So if you have a patient that complains of like a really dark stool, that's usually going to be one of the things to keep in mind. The patient might have peptic ulcer disease. Major things that contribute to peptic ulcer disease: H. pylori. So that's Helicobacter pylori. That's a gram-negative rod. So it's a gram-negative bacteria that doesn't actually like low pH. That's the interesting thing about H. pylori. It prefers to have a more alkaline environment. One of the things that H. pylori does once it gets down to the stomach is that it starts creating its own basic environment. So it starts creating its own basic environment by releasing a lot of like nitrogenous type compounds. And so it's reducing localized, it's increasing the pH in those areas. And now because of that, those areas are now going to be more vulnerable to stomach acids. And so H. pylori is going to be one of the most common causes of peptic ulcer disease. You can test that on a patient using the urea breath test. If the urea breath test comes back positive, then all you do is you treat it with antibiotics. It's a very simple treatment. It can cause a lot of chaos in the stomach if it's untreated, resulting in like severe peptic ulcer disease, but it can be easily treated if you actually do a proper diagnosis. Other things that can cause peptic ulcer disease are going to be NSAIDs, so non-steroidal anti-inflammatory drugs. Okay, so some of the most common ones would be ibuprofen. Aspirin can also cause that. So those types of drugs basically disrupt the mucosal lining of the stomach. You disrupt the mucosal lining, now it's going to be more vulnerable to stomach acids. These are the two most common causes of PUD. Other causes of PUD could be stress, so physical stress, trauma, burns, chronic illnesses. Patients that are hospitalized oftentimes are going to be given omeprazole. So patients that are hospitalized, if they're in there for a period of time, they're going to be given PPIs, and they're going to be given heparin. Heparin, because when you're hospitalized, sometimes you're bedridden during that period of time, so you might run the risk of getting hypercoagulability, right? So you might get like DVTs, maybe pulmonary embolism. But with stress, because of long hospital stays, those patients are usually going to be given some sort of PPI to help reduce the risk of peptic ulcer disease. So you can get them both in your stomach, and you can also get them in the duodenum as well. So those would be referred to as duodenal ulcers. Cool. So let's now talk about the small intestines. The small intestines are going to be subdivided into three major groups. The more proximal portion is the duodenum, pretty short, it's about a foot long. The second portion is going to be the jejunum, and then the final portion is going to be the ileum. Altogether, the small intestines are almost about 20 feet in length, so it's pretty long. In terms of absorption, as I mentioned, like the stomach does absorb a little bit of content, right? But the majority of absorption of most of your nutrients is going to be taking place at the level of your small intestines. So over 90% of your absorption is going to be at the small intestines. In terms of absorption, the mesentery, right? The mesenteric regions of your intestines are going to be responsible for a lot of the absorption. You're going to have a lot of blood vessels that travel through the whole entire region. Those blood vessels are going to be especially important in allowing for nutrients to enter into your systemic circulation. So extremely vascular type system. In terms of secretions, so you have absorption, right? You have absorption of nutrients, but in order to allow for lubrication of the small intestines, to allow for kind of mixing up of the chyme, all the contents that you're trying to digest, you're also going to get a lot of secretions taking place. Back to my wine bottle reference, this is more than 2 bottles of wine that's being secreted by your small intestines. So a lot of fluids are going to be secreted in the small intestines. Some of the important things that those secretions do, it helps to neutralize the pH. Because remember, the stomach is going to be extremely acidic, right? Around 2 in terms of its level of pH. Once you get down to the duodenum, the small intestines, you don't want to have as much acidity. Otherwise, you're going to start compromising the layers of the mucosa within the lumen. So in other words, when you have a lot of the secretion taking place in the small intestines, that's going to help to buffer and increase the level of pH in the chyme. Cool. So let's talk about what's going on at the cellular level. So in terms of the mucosal membranes, in order to maximize the amount of surface area, you're going to have a bunch of little tiny finger-like projections. Those are going to be referred to as villi. Okay? So those are villi. Microvilli are going to be at the cellular level. So each of those individual cells are going to have other little tiny projections as well. They're going to be like villi, but they're going to be microvilli. Those are going to be outpouchings from within the plasma membrane of the cell. And then you're also going to have the brush border. When we talk about the brush border, it's a combination of microvilli plus brush border enzymes. These are enzymes that stay there. They stay at the level of the brush border. They don't move around. In other words, food and nutrients and things like that need to come into direct contact with the brush border enzymes. At that point, the brush border enzymes can further break things down. Sucrose, lactose, things like that, those are all going to be considered brush border enzymes. We'll talk about that in more detail. So here's what the villi look like. You get these little finger-like projections extending out, increasing the surface area. Microvilli, that's going to be at the cellular level. Microvilli, each individual cell is going to have microvilli, and you're also going to see brush border enzymes, and we're going to talk about that in a second. So let's talk about some of the glands that are involved in the small intestine. Remember I mentioned goblet cells. Goblet cells are going to be really important in secreting mucus. That's going to be one of the major mucus-secreting cells. Other cells that are going to be important are going to be endocrine-type cells. CCK, that's cholecystokinin. Secretin is going to be another enzyme that helps to, endocrine compound that helps to release, for instance, pancreatic enzymes. And then you have GIP. There's two different terms for GIP. The one that I'm going to be using is glucose-dependent insulinotropic peptide, but there's also another term for it, it's glucagon-inhibiting peptide, which I'll show you guys later. But that's going to be a really important enzyme that helps to increase insulin levels, and it helps to reduce the amount of gastric motility taking place. This is going to be an enzyme that's released effectively after you eat. You no longer need to eat anymore, so it's going to help to try to reduce gastric motility. It's going to increase the amount of insulin so that you can start absorbing sugars. You're also going to have duodenal glands, Brunner's glands. They're also going to be involved in mucus production as well, which helps to protect the mucosal membrane as well as buffer the pH level. So let's talk about the brush border enzymes real quick before we close out today. The brush border enzymes, just keep in mind that these are not moving around. They don't get secreted. They're going to remain at the level of the mucosal membrane. So the major ones that are important are going to be sucrase, maltase, and lactase. There's also enteropeptidase, which is going to help to convert trypsinogen into trypsin, which we're going to talk about later when we get into the pancreas and what the pancreas does. So keep in mind that this is not secreted, so it's going to be contact-type digestion. All the compounds need to come into direct contact with these different enzymes in order for them to actually do their function. So in terms of trypsin and proteases, so we talked about proteases. Those are going to be some of the enzymes involved in breaking down proteins. Proteases are going to be released by the pancreas. Trypsins are also going to be involving breakdown of proteins as well. There's a couple different types of enzymes here. There's proelastase, which turns into elastase, carboxypeptidases. Don't bog yourself down with these specific enzymes. Just know that trypsins are going to help break things down even further. So it's going to help to break down different types of peptides. Let's see, it's 4:19. I say let's go ahead and continue this on Thursday. So on Thursday, we're going to finish up with part 2. And part 3 is a lot more straightforward, nothing too crazy, so it's going to be a little bit easier. But part 2 is definitely, I think, probably the bulk of the information that you guys need to be comfortable with. So I hope to see you guys in my office tomorrow, and have a great day.